So Aya discussed about the neurodevelopmental disorders. And now we will talk about the schizophrenia spectrum and other psychotic disorders. So, schizophrenia spectrum and other psychotic disorders are defined by abnormalities in one or more of the following five domains. So, the delusions, the hallucinations, the disorganized thinking speech, the grossly disorganized or abnormal motor behavior, including the catatonia and negative symptoms. So, first, let's define delusions. So, delusions are fixed beliefs that are not amendable to change in light of conflicting evidence. So, their content may include a variety of themes. So, delusion is a belief that would be seen by most members of a society as a misinterpretation of reality. So, we have the types of delusions. We have the persecutory delusions, are most common. Small slights may be exaggerated and become the focus of a delusional system. The affected individual may engage in a repeated attempts to obtain satisfaction by legal or legislative action. So, individuals with persecutory delusions are often resentful and angry and may resort to violence against those who are hurting them. So, a common delusion in people with schizophrenia is that others are out to get them. For example, a world class cyclist was on her way to making the Olympic team. Tragically, however, she developed a belief that other competitors were determined to sabotage her efforts, which forced her to stop riding for years. So she believed opponents would spray her bicycle with chemicals that would take her strength away, and they would slow her down by putting small pebbles in the road that only she would ride over. The next type of delusion is the referential delusion. It's believed that certain gestures, comments, or environmental cues and so forth are directed at oneself. So, for example, for this type of delusion is when someone watches a movie and believe there is a message in the movie that is meant specifically for them. So the next type of delusion is the grandiose delusion. It's when an individual believes that he or she has exceptional abilities, wealth, or fame. So the grandiose type of delusion is a belief that a person is famous or powerful. So the media often portray people with schizophrenia as believing they are famous or important people. So for example is a person believed that he could end starvation for all the world's children. Next type is the erotomanic delusions. So the person about whom this conviction is held is usually of higher status but can be a complete stranger. So efforts to contact the object of delusions are common. So the erotomanic type of delusion is the irrational belief that one is loved by another person, usually of a higher status. So some individuals who stalk celebrities appear to have erotomanic type of delusion. So the nihilistic delusion. So nihilistic delusion involves the conviction that a major catastrophe will occur. For example, a person will tell you that there is a big earthquake strike Luzon next year. Next is the somatic delusion. So somatic delusions feels affected by a physical defect or general condition. Examples: believe they have been infected by parasites that have been taken over their internal organs, or tiny insects that have been burrowed under the skin to lay their eggs. So, last type of delusion is the jealous type. The central theme of the delusion is that an unfaithful partner, this belief is arrived at without due cause, is based on the incorrect inference supported by a small bit of evidence. The individual with the delusion usually confronts the spouse or lover and attempts to intervene in the imagined infidelity. Um, in other words, a person with jealous type of delusion believes that a sexual partner is unfaithful. So, delusion that express a loss of control over mind or body are generally considered to be bizarre. We have the thought of withdrawal, thought insertion, and delusions of control. So, thought of withdrawal is the belief that one thought has been removed by outside force. Example, when a person believes that a person or entity has removed thought from his or her mind. Next is the thought of insertion. Thought of insertion that alien thoughts has been put into one's mind. It involves somehow experiencing one thought as someone else's. So delusion of control is one's body or actions are being acted on or manipulated by some outside force. Um, like false belief that another person or group of people or external force controls one's general thoughts. So the next domain we have the hallucination. Um, Hallucinations are perception-like experiences that occur with an external stimulus. So the experience of sensory events without any input from the surrounding environment is called the hallucination. So the type of hallucination we have is the auditory hallucination. So these are usually experienced as voices, whether familiar or unfamiliar, that are perceived as distinct from the individual's own thoughts. So hallucinations can involve any of the senses. Although hearing things that aren't there or hallucination, um, and this is the most common from the experience by people. So next domain we have the disorganized thinking. Disorganized thinking, formal thought disorder is typically inferred from the individual speech. So this include a variety of erratic behavior that affects speech, motor behavior, and emotional reactions. So we have the types of disorganized thinking, the drillment or loose associations, the tangentiality uh, on and incoherence or word salad. The derailment or loss of association is the individual may switch from one topic to another. For example, David abruptly changed the topic of conversation to unrelated areas. So, a behavior that has variously been called um, loose association or adrilement. So tangentiality is answers to questions may be obliquely related or completely unrelated. For example, David didn't really answer the question he was asked. So this type of response is called the tangentiality. So that is going off on a tangent instead of answering a specific question. So the incoherence or word salad is speech may be severely disorganized and that is nearly incomprehensible and resembles or receptive aphasia in its linguistic disorganization. So the words are not related on and not connected to each other. So the fourth domain, we have the grossly disorganized or abnormal motor behavior, including the catatonia. So grossly disorganized or abnormal motor behavior may manifest itself in a variety of ways, ranging from childlike silliness to an unpredictable agitation. So catatonic behavior is marked decrease in reactivity to the environment. So this ranges from resistance to instruction of negativism to maintaining a rigid, inappropriate, or bizarre posture to complete lack of verbal motor responses or mutism and stupor. And it can also include a purposeless and excessive motor activity without obvious cause or um, excitement. So catatonia is one of the most curious symptoms in some individuals with schizophrenia. It involves motor dysfunction that range from wild agitation. Next is the negative symptoms. So negative symptoms account for a substantial um, a portion of the morbidity associated with schizophrenia but are less prominent in the psychotic disorder.
So the negative symptoms usually indicate the absence or insufficiency of normal behavior. They include the apathy, the thought or speech, and emotional and social withdrawal. So under the negative symptoms were the diminish of emotional expression. This include the reduction in the expression of emotions in the face, in the eye contact, the intonation of speech, and movements of the hand, head, and the face that normally give an emotional emphasis to speech. So there are similar to people wearing masks because they do not show emotions when you would normally expect them to. So they may stare at you vacantly, speak in a flat and toneless manner, and seem unaffected by things going on around them. And however, although they do not react openly to emotional situation, they may be responding on the inside. Next is the avolition. So the avolition is the decrease in a motivated, self-initiated, purposeful activities. The individual may sit for a long periods of time and show little interest in the participating in work or social activities. So it's combining the prefix a meaning without and volition which mean is an act of willing. Choosing or deciding abilitation is the inability to initiate and persist in activities. So people with this symptom also referred to as apathy or showing little interest in performing even in the most basic day-to-day functions including those associated with personal hygiene. So another type of negative symptoms, we have the alogia. Alogia is derived from the combination of a without and logos without. Logos is a word. So alogia refers to relative absence of speech. So a person with alogia may respond to questions with brief replies that little content and may appear interested in the conversation. So such deficiency in communication is believed to reflect a negative thought disorder rather than inadequate communication skill. So some researchers, for example, suggest that people with alogia may have trouble finding the right words to formulate their thoughts. So sometimes alogia takes the form of delayed comments or slow responses to questions. So it is So another meaning is alogia is a manifested by diminished speech output. Next is anhedonia. Anhedonia is the decreased ability to experience pleasure from positive stimuli or degradation in the recollection of pleasure previously experienced. So anhedonia is a related symptom which derives the combination of a without and the word hedonic is pertaining to pleasure. So anhedonia is the presumed or lack of pleasure experienced by some people with schizophrenia. So like some mood disorder, anhedonia signals an indifference to activities that would typically be considered pleasurable, including eating, social interactions, and sexual. So lastly, we have the asociality. It refers to the apparent lack of interest in social interactions and may be associated with avolition, but it can also be a manifestation of limited opportunities for social interaction. So let's go on to the disorders. We have the delusional disorder. So delusional disorder, we have the diagnostic criteria. A is the presence of one or more delusions with a duration of 1 month or longer. So B criterion A for schizophrenia has never been met. Letter C, apart from the impact of delusions or its ramifications, functioning is not markedly impaired and behavior is not obviously bizarre or odd. Letter D, if manic or major depressive episodes have occurred, these have been brief relative to the duration of the delusional periods. And letter C is the disturbance is not attributable to the physiological effects of the substance or another medical condition and is not better explained by other mental disorders such as body dysmorphic disorder or obsessive compulsive disorder. So we have it specify whether ito the erythroman type, the grandiose type, the jealous type, and persecutory type, which I discussed earlier. And another is the somatic type and the mixed type. So the mixed type is the subtype applies when no one delusional theme predominates. So the unspecified type is this subtype applies when the dominant delusional belief cannot be clearly determined or it is not described in the specific types or the grandiose type. So this subtype applies when the central theme of delusion is the conviction of having some great but unrecognized or talent or insight or having made some important discovery. And it specify also with bizarre content. Delusions are deemed bizarre if they are clearly implausible or not understandable and not derived from ordinary experiences. So another is lastly is the specify if the following course specifiers are not only be used after 1 year duration of the disorder. We have the first episode currently in acute episode, first episode currently in partial remission, and first episode currently in full remission. So the first episode currently in acute episode is the first manifestation of the disorder meeting the defining diagnostic system and time criteria. So, an acute episode is a time period in which the symptom criteria are fulfilled. So, the first episode currently in a partial remission is a remission is a type period during which an improvement after a previous episode is maintained, and which the defining criteria of the disorder are only partially fulfilled. So the first episode currently in full remission is full remission is a period of time after a previous episode during in which no disorder's specific symptoms are present. So let's go to the diagnostic features of delusional disorder. So the essential feature of a delusional disorder is the presence of one or more delusions that persist for at least 1 month in criterion A. So a diagnosis of delusional disorder is not given if the individual has ever had a symptom presentation that met criterion A for schizophrenia in criterion B. Apart from the direct impact of delusions, impairments in psychosocial function may be more circumscribed than those seen in other psychotic disorders such as schizophrenia, and behavior is not obviously bizarre or odd in criterion C. So if mood episode occur currently with the delusions, the total duration of this mood episode is brief relative to the total duration of the delusional periods in the criterion D. So the delusions are not attributable to the physiological effects of a substance such like cocaine or another medical condition such as Alzheimer's disease, and are not better explained by another mental disorder such as body dysmorphic disorder or obsessive compulsive disorder in criterion E. So in associated features supporting diagnosis, so social, marital, or work problems can result from the delusional beliefs of delusional disorder. So individuals with delusional disorder may be able to factually describe the others' view their beliefs as irrational but are unable to accept this themselves. Like there may be factual insight but not true insight. So many individuals develop irritable or dysmorphic mode, which can usually be understood as a reaction to their delusional beliefs. So anger and violent behavior can occur with persecutory, jealous, and erythromany types. So the individual may engage in litigious or antagonistic behaviors as sending hundreds of letters of protest to the government. So legal difficulties can occur particularly in jealous and erythromany types. So, in development and course, on average, global function is generally better than the observed in schizophrenia, although the diagnosis is generally stable. A proportion of individuals go on to develop schizophrenia, so delusional disorder has a significant familiar relationship with both schizophrenia and schizotypal personality disorder. So, although it can occur in younger age groups, the condition may be more prevalent in older individuals. So the lifetime prevalence of delusional disorder has been estimated around 0.2%, and the most frequent subtype is persecutory. So delusional disorder, the jealous type, is probably more common in males than in females. But there is no major gender differences in the overall frequency of delusional disorder. So the culture-related diagnostic issues. So an individual cultural and religious background must be taken into account in evaluating the possible presence of delusional disorders. So the content of delusions also varies across cultural contexts. So, in differential diagnosis, we have the obsessive compulsive and related disorders, the delirium major neurocognitive disorder, psychotic disorder due to another medical condition, and substance medication in induced psychotic disorder, the schizophrenia and schizophrenic disorder, and lastly the depressive and bipolar disorders and schizoactive disorder. So the obsessive compulsive and related disorders, if an individual with obsessive compulsive disorder is completely convinced that his or her obsessive compulsive disorder beliefs are true, then the diagnosis of obsessive compulsive disorder with absent insight delusional beliefs is a fire should be given rather than a diagnosis of delusional disorder. So delirium major neurocognitive disorder or psychotic disorder due to another medical condition and substance medication induced psychotic disorder. So individuals with these disorders may present with symptoms that suggest delusional disorder. For example, simple persecutory delusions in the context of major neurocognitive disorder would be diagnosed as major neurocognitive disorder with behavioral disturbance. So the schizophrenia and schizophrenic disorder is delusional disorder can be distinguished from schizophrenia and schizophrenic disorder by the absence of the other characteristic symptoms of the active phase of schizophrenia. Lastly, the depressive and bipolar disorders and schizoactive disorder. So these disorders may be distinguished from delusional disorder by the temporal relationship between the mood disturbance and the delusions and by the severity of the mood symptoms. So the next disorder, we have the brief psychotic disorder. So the diagnostic criteria is the presence of one or more of the following symptoms. At least one of these must be 1, 2, or 3. We have the delusions, the hallucinations, the disorganized speech that include the frequent derailment or incoherence, and the grossly disorganized or catatonic behavior. So letter B, duration of an episode of disturbance is at least 1 day but less than 1 month, with eventual full return to the premorbid level of functioning. Letter C is the substance is not better explained by a major depressive or bipolar disorder with psychotic features or another psychotic disorder such as schizophrenia or catatonia, and it is not attributable to the physiological effects of a substance such as drugs of abuse, a medication, or another medical condition. So we have the specify if with catatonia without marked stressors and with postpartum onset. With marked stressors, it is like brief reactive psychosis. If symptoms occur in response to events that singly or together, and would be markedly stressful to almost anyone in similar circumstances in the individual's culture. So without marked stressors, if symptoms do not occur in response to events that singly or together would be markedly stressful to almost anyone in similar circumstances in the individual's culture. With postpartum onset, if the onset is during pregnancy or within 4 weeks postpartum. In diagnostic features in brief psychotic disorders, the essential feature of brief psychotic disorder is a disturbance that involves the sudden onset of at least one of the following positive psychotic symptoms: the delusions, the hallucination, the disorganized speech, or grossly abnormal psychomotor behavior, the frequent derailment, or incoherence that including catatonia in criterion A. The sudden onset is defined as a change from a non psychotic state to a clearly psychotic state within 2 weeks, usually without prodrome. An episode of the disturbance lasts at least 1 day but less than 1 month, and the individual events has a full return to the premorbid level of functioning. So, the disturbance is not better explained by a depressive or bipolar disorder with psychotic features, by psychotic by schizoaffective disorder or by schizophrenia, and is not attributable to the physiological effects of a substance including the hallucinogen or another medical condition such as subdural hematoma in criterion C. In associated features supporting the diagnosis, individuals with brief psychotic disorder typically experience emotional turmoil or overwhelming confusion. They may have rapid shift from one intense affect to another, and although the disturbance is brief, the level of impairment may be severe, and supervision and may be required to ensure that nutritional and hygienic needs are met and that the individual is protected from the consequences of poor judgment, cognitive impairment, or acting on the basis of delusions. So, this appears to be the increased risk of a suicidal behavior, particularly during the acute episode. So, um, in the development and course, um, the brief psychotic disorder may be appear in the adolescent or early adulthood, and onset can be occur across the lifespan, with the average age onset being in the mid 30s. When we talk about the culture-related diagnosis, it is important to distinguish symptoms of a brief psychotic disorder from culturally sanctioned response pattern. Like, for examples, in some religious ceremonies, an individual may report hearing voices but this not generally persist and are not perceived as abnormal by most members of the individual's community. So, in addition, cultural and religious background must be taken into the account when considering whether beliefs are delusions. So, the differential diagnosis in brief psychotic disorders are other medical conditions, substance related disorders, the depressive and bipolar disorders, other psychotic disorders, malingering and factitious disorders, and personality disorders. In other medical conditions, a variety of medical disorders can manifest with psychotic symptoms of short duration. In substance related disorders, medication-induced psychotic disorders, substance-induced delirium, and substance intoxication are distinguished from brief psychotic disorder by the fact that a substance like a drug abuse a medication exposure to a toxin is judged to be etiologically related to the psychotic symptoms. The depressive and bipolar disorders, the diagnosis of brief psychotic disorders cannot be made if the psychotic symptoms are better explained by the mood episode, which is the psychotic symptoms occur exclusively during a full major depressive, manic, or mixed episode. The other psychotic disorders, um, if the psychotic symptom persists 1 month or longer, the diagnosis is either schizophreniform disorder and delusional disorder, depressive disorder with psychotic features such as bipolar disorders with psychotic features, or other specified or unspecified schizophrenia spectrum, and other psychotic disorder depending on the other symptoms in the presentation. So, malingering and factitious disorders, an episode of factitious disorder with predominant, predominantly psychological signs and symptoms may have the appearance of a brief psychotic disorder, but in such cases, there is evidence that the symptoms are intentionally produced. In personality disorder, in certain individuals with personality disorders, psychosocial stressors may precipitate brief periods of psychotic symptoms. So, in diagnostic criteria in schizophreniform disorder is A is two or more of the following, each present for a significant portion of time during 1 month period or less if successfully treated. At least one of these must be 1, 2, or 3. So we have the delusions, the hallucination, the disorganized speech, the grossly disorganized or catatonic behavior, and negative symptoms. B. An episode of the disorder lasts at least 1 month but less than 6 months when the diagnosis must be made without waiting for recovery. So it should be qualified as provisional. So letter C is the schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out because either one, no major depressive or manic episodes have occurred currently with the active phase symptoms, or two. If mood episodes have occurred during active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness. And letter D, the disturbance is not attributable to the physiological effects of a substance such as a drug of abuse, a medication, or another medical condition. So diagnostic criteria for specify if with good prognostic features and without good prognostic features, and specify it if with catatonia. With good prognostic features, this specifier requires the presence of at least two of the following features: the onset of the prominent psychotic symptoms with 4 weeks of the first noticeable change in usual behavior or functioning, confusion or the perplexity, good premorbid social and occupational functioning, and the absence of blunted or flat affect. Without good prognostic features, this specifier is applied if two or more of the above features have not been present. So, in diagnostic features in schizophreniform disorder, the characteristic symptoms of schizophreniform disorder are identical to those of schizophrenia in criterion A. So, schizophreniform disorder is distinguished by its difference in duration. So, the total duration of the illness, including prodromal, active, and residual phases, at least 1 month, but at least 6 months in criterion B. So, the diagnostic of schizophreniform disorder is made under two conditions: when an episode of illness at least between 1 and 6 months in the individual has already recovered, and 2, when an individual is symptomatic for less than the 6 months duration required for the diagnostic of schizophrenia but has not yet recovered. So in this case, the diagnosis should be noted as schizophreniform disorder or provisional because it is uncertain if the individual will recover from the disturbance within the 6 months period. If the disturbance persists beyond 6 months, the diagnosis should be changed to schizophrenia. So the differential diagnosis is another mental disorders and medical conditions is where the variety of mental and medical condition can manifest with psychotic symptoms that must be considered in the differential diagnosis of schizophreniform disorder. And the brief psychotic disorder. Schizophreniform disorders differs in duration from brief psychotic disorder which has a duration of at least less than 1 month. So let's move on to schizophrenia. So schizophrenia, the diagnostic criteria, two or more of the following, each present for a significant portion of time during 1 month period or less if successfully treated. At least one of these must be delusions, the hallucinations, the disorganized speech, the grossly disorganized or catatonic behavior, last is negative symptoms. So, for a significant proportion of the time since the onset of the disturbance, level of functioning in one or more major areas such as work, interpersonal relation, or self-care is markedly below the level achieved prior to the onset, or when the onset in childhood or adolescence there is a failure to achieve expected level of interpersonal, academic, or occupational functioning. So it continues, the signs of the disturbance persist for at least 6 months. So this 6 months period must include at least 1 month of symptoms or less if successfully treated that meet criterion, and may include periods of the prodromal or residual symptoms. During these prodromal or residual periods, the signs of the disturbance may be manifested by only negative symptoms or by two or more symptoms listed in criterion A present in attenuated form. So schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out because either one, no major depressive or manic episodes have occurred concurrently in the active phase symptoms, or two, if mode episodes have occurred during active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness. So the disturbance is not attributable to the physiological effects of a substance or another medical condition. So if there is a history of autism spectrum disorder or a communication disorder of a childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to other required symptoms of schizophrenia, are also present for at least 1 month or less if successfully treated. So it specifies if the following course specifiers are only to be used after 1 year duration of the disorder, and if they are not in contradiction to diagnostic course criteria. Specify is first episode currently in acute episode, first episode currently in partial remission, first episode currently in full remission, and multiple episode currently in acute episode, and specify if with catatonia. So the first person currently in acute episode, first manifestation of disorder meeting the defining diagnostic symptom and criteria. So an acute episode is the time period in which the symptom criteria are fulfilled. So first episode currently in a partial remission, or partial is a period of a time during which an improvement after a previous episode is maintained and in which the defining criteria of disorders are only partially fulfilled. So first episode currently in full remission, the full remission is a period of a time after a previous episode during which no disorder-specific symptoms are present. So in diagnostic features for schizophrenia, the characteristic symptoms of schizophrenia involve a range of cognitive, behavioral, and emotional dysfunctions, but no single symptom is pathognomonic of the disorder. The diagnostic involves the recognition of a constellation of signs and symptoms associated with impaired and occupational or social functioning. So the associated features supporting diagnosis: individual with schizophrenia may display inappropriate affect, a dysmorphic mood that can take the form of depression, anxiety, or anger, a disturbed sleep pattern and a lack of interest in eating or food refusal, dispersonalization, derealization, and somatic concerns may occur and sometimes reach delusional proportions. So anxiety and phobias are common. So cognitive deficit in schizophrenia are common and are strongly linked to vocational and functional impairments. For risk and prognostic factors, we have the environmental and genetic and physiological. For environmental, season of birth has been linked to the incidence of schizophrenia, including late winter or early spring in some location and summer for the deficit form of the disease. The incidence of schizophrenia and related disorders is higher for children growing up in an urban environment and for some minority ethnic groups. For genetic and physiological, there is a strong contribution for genetic factors in determining risk for schizophrenia. Although most individuals who have been diagnosed with schizophrenia have no family history of psychosis. In gender-related diagnostic issues, a number of features distinguish the clinical expression of schizophrenia in females and males. The general incidence of schizophrenia tends to be slightly lower in females, particularly among treated cases. In suicide risk, approximately 5% and 6% of individuals with schizophrenia die by suicide. About 20% attempt suicide on one or more occasions, and many more have significant suicidal ideation. In functional consequences of schizophrenia, schizophrenia is associated with significant social and occupational dysfunction, making educational progress and maintaining employment are frequently impaired by avolition or other dis- disorder manifestation. Even when the cognitive skills are sufficient for the task at hand, most individuals are employed at a lower level than their parents, and most particularly men do not marry or have limited social contacts outside of their family. So when we talk about the differential diagnosis in schizophrenia, we have the major depressive or bipolar disorder with psychotic or catatonic features, the schizoaffective disorder, the schizophreniform disorder and brief psychotic disorder, the delusional disorder, the schizotypal personality disorder, the obsessive compulsive disorder and body dysmorphic disorder, the post-traumatic stress disorder, the autism spectrum disorder or communication disorders, and other mental disorders associated with psychotic episodes. So the major depressive or bipolar disorder with psychotic or catatonic features, if delusions or hallucination occur exclusively during a major depressive or a manic episode, the diagnosis is depressive or a bipolar disorder with psychotic features. In schizoaffective disorder, a diagnosis of a schizoaffective disorder requires that a major depressive or a manic episode occur currently with their active phase symptoms and that the mood symptoms be present for a majority of the total duration of the active periods. For the schizophreniform disorder and brief psychotic disorder, these disorders are of shorter duration than schizophrenia are specified in criterion C, which requires 6 months of symptoms. For delusional disorder, the delusional disorders can be distinguished from schizophrenia by the absence of the other symptoms characteristic of schizophrenia, such as delusions, prominent auditory or visual hallucination, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. The schizotypal personality disorder may be distinguished from schizophrenia by subthreshold symptoms that are associated with persistent personality features. Obsessive compulsive disorder and body dysmorphic disorder. Individuals with compulsive disorder and body dysmorphic disorder may be present with poor or absent insight, and the preoccupations may reach delusional proportion. But these disorders are distinguished from schizophrenia by their prominent obsessions, compulsions, preoccupation with appearance or body odor, hoarding, or body focus, repetitive behaviors. In post traumatic disorder may include flashbacks that have hallucinatory quality, and hypervigilance may reach in paranoid proportions. But a traumatic event and characteristic symptoms features relating to reliving or reacting to the event are required to make the diagnosis. For autism spectrum disorder or communication disorders, these orders may also have symptoms resembling a psychotic episode but are distinguished by their respective in social interaction with repetitive and restrictive behaviors and either cognitive and communication deficits. Other mental disorders associated with psychotic episodes, the diagnosis of schizophrenia is made only when the psychotic episode is persistent and not attributable to the physiological effects of the substance or another medical condition. So, when we talk about the comorbidity of schizophrenia, rates of comorbidity with substance related disorders are high in schizophrenia. Over half of individuals with schizophrenia have tobacco use disorder and smoke cigarettes regularly. comorbidity with anxiety disorders, and increasingly recognized in schizophrenia. So rates of obsessive compulsive disorder and panic disorders are elevated in individuals with schizophrenia compared with the general population. So schizotypal or paranoid personality disorder may sometimes precede to the onset of schizophrenia. So let's go to schizoaffective disorder. The diagnostic criteria: A is an uninterrupted periods of illness during which there is a major mood episode, a major depressive or manic, concurrent with criterion A of schizophrenia, delusions or hallucinations for 2 or more weeks in the absence of a major mood episode, depressive or manic during the lifetime duration of the illness. And letter C is the symptoms that meet criteria for a major mood episodes are present for the majority of the total duration of the active and residual portion of the illness. And letter D is the disturbance is not attributable to the effects of a substance or another medical condition. And it specify whether bipolar type, this subtype applies if a manic episode is part of the presentation, or major depressive episodes may also occur. The depressive type, this subtype applies if only major depressive episodes are part of the presentation, and it specify if with catatonia. Also specify if the following occurs specify only to be used after 1 year duration of the disorder, and if they are not contradiction to the diagnostic course criteria. First episode currently in acute episode, first episode currently in a partial remission, first episode currently in full remission, and multiple episode currently in acute episode. For diagnostic features, the diagnosis of a schizoaffective disorder is based on the assessment of an interrupted period of illness during which the individual continues to display active or residual symptoms of psychotic illness. So diagnosis is usually but not necessarily made during the period of psychotic illness. In associated features supporting diagnosis, there are no tests or biological measures that can assist in making diagnosis of schizoaffective disorder. Whether schizoaffective disorder differs from schizophrenia with regard to associated features such as structural or functional brain abnormalities, cognitive deficits, or genetic risk factors is not clear. For the prevalence schizoaffective disorder appears to be about one-third as common as schizophrenia. Lifetime prevalence of schizoaffective disorder is estimated to be 0.3%. The incidence of schizoaffective disorder is higher in females than in males, mainly due to increased incidence of the depressive type among females. For the risk and prognostic factors, in genetic and physiological, among individuals with schizophrenia, there be an increase for schizoaffected in the first degree relatives. The risk for schizoaffective may be increased among individuals who have first degree relative with schizophrenia, the bipolar disorder, or schizoaffective disorder. For culture related diagnosis issues, cultural and socio-economic factors must be considered, particularly when individual and the clinicians do not share the same cultural and economic background. Ideas that appear to be delusional in one culture may be commonly held in another. For the suicide risk, the lifetime risk of a suicide for schizophrenia and schizoaffective disorder is 5%, and the presence of the depressive symptom is correlated with higher risk for suicide. For the sixth affective differential diagnosis, we have the other mental disorders and medical conditions. So, a wide variety of psychiatric and medical conditions can manifest the psychotic and mood symptoms that must be considered in the differential diagnosis of schizoaffective disorder. For the psychotic disorder due to another medical condition, other medical conditions and substance use can manifest with a combination of psychotic and mood symptoms, and the psychotic disorder due to another medical condition needs to be excluded. For the schizophrenia, bipolar, and depressive disorders, distinguishing affective disorder from schizophrenia and from depressive and bipolar disorder with psychotic features is often difficult. For the um, comorbidity. So many individuals diagnosed with schizoaffective disorder are also diagnosed with other mental disorders, especially substance use disorders and anxiety disorders. So similarly, the incidence of medical condition is increased above base rate for the general population and leads to decreased the life expectancy. So let's go to the substance, medication, and induced psychotic disorders. For the diagnostic criteria, presence of one or both of the following symptoms have delusions and hallucinations. Letter B, there is evidence from the history and physical examination or laboratory findings of both 1 and 2. The symptoms in criterion A develop during or soon after substance intoxication or withdrawal or after exposure to a medication. Two is the involved substance medication is capable of producing the symptoms in criterion A. Letter C, the disturbance is not better explained by a psychotic disorder that is not substance medication induced, such as evidence of an independent psychotic disorders could include the following. The symptoms preceded the onset of the substance medication use. The symptoms persist for a substantial period or after the sensation of acute withdrawal or severe intoxication, or there is other evidence of an independent non-substance medication-induced psychotic disorders. Letter D, the disturbance does not occur exclusively during the course of delirium. And letter E, the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. So, in diagnostic features, the essential features of substance medication-induced psychotic disorders are prominent delusions and or hallucination in criterion A that are judged to be due to the physiological effects of a substance medication, including a drug of abuse, a medication, or a toxin exposure. A substance medication-induced psychotic disorder is distinguished from a primary psychotic disorder by considering the onset, course, and other factors. Substance medication-induced psychotic disorders arise during or soon after exposure to a medication or after substance intoxication or withdrawal, but can persist for weeks, whereas primary psychotic disorders may precede the onset of substance medication use or may occur during times of sustained abstinence. One initiated the psychotic symptoms may continue as long as the substance medication use continues. For the associated features supporting the diagnosis, psychotic disorders can occur in association with intoxication with the following classes of substances: the alcohol, the cannabis, the hallucinogens, including the uh, phencyclidine and related substances, the inhalants, the sedatives, the hypnotics, and anxiolytics stimulants, including cocaine and other or unknown substances. Psychotic disorders can occur in association with withdrawal from the following classes of substances: the alcohol, sedatives, hypnotics, and anxiolytics, and other unknown substances. The prevalence of substance medication-induced psychotic disorder in the general population is unknown. Between 7% and thus 25% of individuals presenting with the first episode of psychosis in different settings are reported to have substance medication-induced psychotic disorder. So in differential diagnosis, we have the substance intoxication of substance withdrawal, individuals intoxicated with stimulants, cannabis, or the opioid meperidine or mepincyclidine, or those withdrawing from alcohol or sedatives may experience altered perceptions that they recognize as drug effects. Primary, the psychotic disorder. A substance medication-induced psychotic disorder is distinguished from a primary psychotic disorder such as schizophrenia, schizoaffective disorder, delusional disorder, psychotic disorder, other specified schizophrenia spectrum and other psychotic disorder, or unspecified schizophrenia spectrum and other psychotic disorder, by the fact that a substance is adjudged to be etiologically related to the symptoms. To the psychotic disorder due to another medical condition, a substance medication-induced psychotic disorder due to a prescribed treatment for a mental or medical conditions have its onset while the individual is receiving the medication or during withdrawal if there's a withdrawal syndrome associated with the medication. For the psychotic disorder due to another medical condition, we have the diagnostic criteria: permanent hallucinations or delusions. We have letter B, there is evidence from the history, physical examination, or laboratory findings that the disturbance is direct pathophysiological consequence of another medical conditions. The disturbance is not better explained by another mental disorder. No, the disturbance does not occur exclusively during the course of delirium. And letter E, the disturbance causes clinically significant stress or impairment in social, occupational, or other important areas functioning. For the specifiers, in addition to the symptom domain areas identified in the diagnostic criteria, the assessment of cognition, depression, and mania symptom domains is vital for making critically important distinction between the various schizophrenia spectrum and other psychotic disorders. So the diagnostic features, the essential feature of psychotic disorder due to another medical condition are prominent delusions or hallucinations that are judged to be attributable to the physiological effects of another medical conditions that are not better explained by another mental disorder. Um, Example, the symptoms that are not physiologically mediated response to a severe medical condition, in which case a diagnosis of brief psychotic disorder with marked stressor would be appropriate. So, in determining whether the psychotic disturbance is attributable to another medical condition, the presence of medical condition must be identified and considered to be the etiology of the psychosis through a psychological mechanism. One consideration is the presence of the temporal association between onset, exacerbation, or remission of the medical condition that of the psychotic disturbance. The second consideration is the presence of features that are atypically for a psychotic disorder, a typical age that onset, and the presence of visual or olfactory hallucinations. The disturbance must also be distinguished from substance medication psychotic disorder or another mental disorder, in example, just adjustment disorder. For when we talk about the associated features supporting diagnosis, the temporal association of the onset of exacerbation of the medical conditions offers the greatest diagnostic certainty that the delusion or hallucinations are attributable to the medical condition. Additional factors may include the concomitant treatments for the underlying medical condition that are confer a risk of psychosis independently, such as steroid treatment for autoimmune disorders. For the risk and prognostic factors, cause modifiers, identification, and treatment of the underlying medical condition has the greatest impact on course, although pre-existing central nervous system injury may confer a worse course outcome. For the suicide risk in the context of psychotic disorder to another medical condition is not clearly delineated, although certain conditions such as epilepsy and multiple sclerosis are associated with increased rates of suicide, which may be further increased in the presence of psychosis. For the prevalence rates for the psychotic disorder to another medical condition are difficult to estimate given in the wide variety of underlying medical etiologies. However, for the differential diagnosis for the psychotic disorder due to another medical conditions, we have delirium, the substance medication in the psychotic disorders, and the psychotic orders. The delirium, hallucination, and delusions commonly occur in the context of a delirium. However, a separate diagnosis of a psychotic disorder due to another medical condition is not given if the disturbance occurs exclusively during the course of a delirium. Substance medication induce psychotic disorder if there is evidence of a recent or prolonged substance use, including medication with psychoactive effects, withdrawal from a substance, or exposure to a toxin. For a psychotic disorder due to another medical condition must be distinguished from a psychotic disorder such as the schizophrenia, delusional disorder, schizoaffective disorder, or depressive bipolar disorder with psychotic features. For the comorbidity, psychotic disorder due to another medical condition in individuals older than 80 years is associated with concurrent major neurocognitive disorder or dementia. So catatonia can occur in the context of several disorders including neurodevelopmental, psychotic, bipolar, depressive disorders, and other medical conditions. So catatonia is defined by the presence of three or more psychomotor features in the diagnostic criteria for catatonia associated with another mental disorder and catatonic disorder due to another medical condition. The essential feature of catatonia is a marked psychomotor disturbance that may involve decreased motor activity, decreased engagement during interview or physical examination, or excessive and peculiar motor activity. So under this is the catatonia associated with another mental disorder of catatonia specifier. The clinical picture is dominated by three or more of the following symptoms. So we have the stupor. The stupor is no psychomotor activity not actively relating to environment or like it is not unconscious. For catalepsy, it is a passive induction of a posture held against gravity or like is a mark of loss of voluntary motion in which the limbs remains in whatever position they are placed. Wax flexibil wax flexibility. The wax flexibility is slight even recent positioning by examiner. So it's like a condition in which a person limbs retain any position into which they are manipulated by another person. For the mutism is the no or very little verbal response exclude if known aphasia. So absence of a speech while conserving or maintaining the ability to hear the speech of others. So negativism is the opposition or no response to instructions or external stimuli, refusing to do something. For posturing is the spontaneous and active maintenance of a posture against gravity. For mannerism is like odd, circumstantial caricature of normal actions or like habitual acts. For stereotypy is repetitive, abnormal, frequent, and non-goal directed movements. Agitation is not influenced by external stimuli. We have number 10 is the grimacing, and number 10 is echo echolalia. Echolalia is like um, mimicking another speech. The echoprasia is mimicking another movements. For diagnostic features, catatonia associated with another mental disorder or catatonia specifier may be used when criteria are met for catatonia during the course of a neurodevelopmental, psychotic, bipolar, depressive, or other mental disorder. So catatonia is typically diagnosed in an inpatient setting and occurs in up to 35% of individuals with schizophrenia. But the majority of catatonia cases involve individuals with depressive or bipolar disorders. So there must have evidence from the history or the French physical examiner or the laboratory findings that the catatonia is attributable to another medical condition. The diagnosis is not given if the catatonia is better explained by another mental disorder like a manic episode for the criterion C, or if it occurs exclusively during the course of delirium in criterion D. For catatonic disorder due to another medical condition, for the diagnostic criteria, the clinical picture is dominated from the three or more of the following symptoms that I mentioned. These are mentioned earlier. For letter B, there is no evidence from the history, physical examination, or laboratory findings that the disturbance is the direct pathophysiological consequences of another medical condition. The disturbance is not better explained by another mental disorder as like a manic episode. The disturbance does not occur exclusively during the course of a delirium, and the disturbance causes clinically significant distress or impairment in social or occupational or other important areas of functioning. The diagnostic features, the essential feature of catatonic disorder to another medical condition is the presence of the catatonia that is judged to be attributed to the physiological effects of another medical condition. Catatonia can be diagnosed by the presence of at least of the 12 clinical features in Criterion A. For the differential diagnosis, a separate diagnosis of catatonic disorder due to another medical condition is not given if the catatonia occurs exclusively during the course of a delirium of neuroleptic malignant syndrome. Catatonic symptoms may be present in any of the following five psychotic disorders: brief psychotic disorder, the schizophrenia disorder, the schizophrenia schizoaffective disorder, and substance medication-induced psychotic disorder. So it may also present in some of the neurodevelopmental disorders, in all of the bipolar and depressive disorders, and in other mental disorders. For the unspecified catatonia, this category applies to the presentation in which symptoms characteristics of catatonia cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, but either the nature of the following underlying mental disorder or other medical condition is unclearly full criteria for catatonia are not met, or this is insufficient information to make a more specific diagnosis. To other specified schizophrenia spectrum and other psychotic disorder, this category applies to presentation in which symptoms characteristics of a schizophrenia spectrum and other psychotic disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning and predominate but do not meet the full criteria for any of the disorders in the schizophrenia spectrum and other psychotic disorders diagnostic class. The other specified schizophrenia spectrum and other psychotic disorder category is used in situations in which the clinicians chooses to communicate the specific reasons that the presentations that not meet the criteria for any specific schizophrenia spectrum and other psychotic disorder. So this is done by recording other specified spectrum and other psychotic disorder followed by the specific reason. Lastly, unspecified schizophrenia spectrum and other psychotic disorder. This category applies to the presentation in which symptoms characteristics of a schizophrenia spectrum and other psychotic disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any of the disorders in the schizophrenia spectrum and other psychotic disorders diagnostic class. The unspecified schizophrenia spectrum and other psychotic disorders category is used in situations in which the clinician chooses not to specify the reason that the criteria are not meant for a specific schizophrenia spectrum and other psychotic disorder, and it includes presentation in which there is insufficient information to make a more specific diagnosis. So that's all, and thank you.